So I'm very, very excited to introduce Dr. Rustin Zomorodi. He is here for an interview as part of a faculty recruitment in the Division of Infectious Diseases and Global Public Health, and also to the Owing Clinic. And I apologize, Rustin, for all the technical difficulties. This isn't a test to see how you do under pressure. Anyway, Rustin is an infectious diseases physician from Los Angeles, and he was inspired by his early experiences as an HIV counselor at the Berkeley Free Clinic. He earned his MD and NPH at Case Western Reserve University, where he developed community-based HIV PrEP initiatives. He completed residency and infectious diseases fellowship training at Mount Sinai and Elmhurst Hospital in New York City. And he focused on HIV primary care, STI prevention, and outbreak response. And during his fellowship, he contributed to Mount Sinai's Mpox response and collaborated with the New York City Health Department on a citywide Mpox research cohort. And he's currently a clinical assistant professor of infectious diseases at USC with academic interests in HIV prevention, emerging diseases, and climate-linked infectious diseases and public health implementation. And I hope many of you will get to meet him today. He's going to take a tour of the Hillcrest campus and Owen Clinic. And welcome, Rustin. I'll hand it over to you.
Great. Thank you so much for having me, and thank you for everyone who's joined us online. I see some familiar faces in the audience, and that warms my heart a great deal. So apologies for the technical difficulties and starting late. This talk is going to have a little bit more content than I'll get through, but I figured I would leave some more data for you to look through a bit later. So I'm going to talk today about Mpox and what we learned from our initial outbreak in New York City and what that means for infections going forward and how we can prepare for the next Mpox. So I'm going to go over our clinical experience in New York City in summer 2022. I'm going to go over what our public health response was and what we looked at with the Department of Health for our research cohort. Then I'm going to look at how Mpox has evolved and what epidemiology has looked like since 2024 up to now. I'm going to look through vaccine and therapeutic guidance and challenges that we still face and what that means for emerging infectious diseases going forward. Okay, so spillovers, as some of you may know, and many of you might learn in the future, are a special interest of mine. So I am going to be talking about why Mpox still matters to us for a number of reasons. So Mpox was really a sentinel event in a number of ways. The clade 2B outbreak that we saw in summer 2022 was the first major viral outbreak to spread across sexual networks in the modern HIV era. It spread quite rapidly and required immediate clinical awareness, despite not really knowing the details of the pathogen, public health coordination, directly engaging with our communities, getting whatever therapies we could available and accessed. I'll talk about why that was difficult, and being sensitive to stigma around it and healthcare communication. And as we'll see, our existing HIV and STI infrastructure was really what became the frontline response infrastructure that we relied on. So looking at Mpox requires us to think of it as a syndemic. So just to define what that means, when two or more diseases or conditions cluster together in a population and interact, because of social determinants of health, structural inequities, that burden of disease is exacerbated and health disparities get worse in tandem. So along with HIV and STI care, Mpox fits into that and must be approached through a syndemic lens. So we can't look at just the treatments, we have to look at everything that is going into making those interact with each other and contribute to worse health outcomes in tandem. All right, so at Mount Sinai, I'm going to go through some of our data rather quickly, but I'm going to be looking at our institutional experience from summer 2022, when Mpox was new to all of us. So we ended up publishing our data in COVID with an alumni, my co-fellow, Christopher Bowe. So hopefully he gets a chance to look at this later. Just a review of what typical Mpox lesions look like. Not always progressing in this classic pattern or at the concurrent stage. I'll go over when you might see that or when you might not. But just some examples of typical lesions. Billy vesicles going on to pustules, umbilicating, then ulcerating, crusting, and scabbing over eventually. Depending on the clade of infection, where you see these lesions vary, and the timing of them and severity of them. But we'll go over that a bit later. So in our cohort, we had 130 people included over that summer period. We saw, as we'll see throughout the outbreak, the majority of the same cohort, young men who have sex with men, disproportionately white in our cohort, about half, and about 60% living with HIV. And you would see that across the city. Of the remainder, about half of those were on PrEP for HIV. So a large number already actively engaged in some form of HIV treatment, whether it was prevention or for treatment of known HIV. And then our cohort did include a wide range of immunosuppressive conditions. We included HIV with low CD4 count and viral load detectable with the severely immunocompromised group. As seen in the city, we had high numbers of concurrent STI diagnoses as well, lower than seen citywide because we used telehealth. And then, as you would see throughout the outbreak, anorectal and genital lesions were common in the majority of patients. Most had some level of viral syndrome, such as fevers and chills, and 90% had lab-confirmed Mpox through a combination of testing modalities. Our cohort had relatively favorable HIV viral load and CD4 count, so we saw similar outcomes with our cohort overall compared to patients who didn't have immunocompromising conditions. Okay, and we had 18 out of our 130 patients hospitalized. Generally because of a superimposed bacterial infection was the most common, but pain in sensitive areas was also pretty critical. And overall, our key outcomes, we saw no significant differences between people living with HIV and without an immunocompromising condition. We saw a higher risk of hospitalization, though, for patients who had severe immunocompromise. So that included a range of immunocompromising conditions, but it also included HIV with a low CD4 count and detectable viral load. Primary reason, as I mentioned, for bacterial superinfection. Okay. I'm going to contextualize this within the New York City response, as that was present essentially from the beginning of our work as an institution and continued afterwards as well. So over the summer and into the fall, you saw about 3,800 cases in New York City. Just to get a sense of the spread, majority in Manhattan of those that we saw, the age range falling into middle age, majority male, and generally LGBTQ. Vaccination coverage over that same time period, the darker lines showing first dose, the lighter showing the second dose. So by the end of this period, by January 2023, we had about 50,000 with both doses. And we did see large disparities in immunization rates compared to the proportion of actual cases. We didn't see a difference by borough, age group, gender, or sexual orientation, but we did see that minority groups that had the largest proportion of cases had lower vaccination rates overall. So in Hispanic and Latino folks, as well as African American Black folks, we had disproportionate rates of cases compared to vaccination and second dose in particular. So in patients that were taking tecovirimat for Mpox, we collected data on them to see if outcomes were different in any of the groups that we broke down by demographics. We had about 708 patients included citywide who took tecovirimat. And compared to our cohort, as I mentioned, concurrent STIs were similar, as well as a proportion of patients who had HIV. We included deaths from Mount Sinai and hospitalized patients, again, had similar reasons for hospitalization. Notably, dysphagia or obstruction because of location of lesions was very important in hospitalized patients and led to longer stays in many of their cases. Okay. These outcomes were again published in CID. We saw essentially that outcomes were similar to our cohort, but it included a larger case count with longer courses and more severe outcomes overall because of that. Overall, non-Hispanic Black patients had a higher risk of initiating tecovirimat with a delay, so greater than or equal to 8 days after onset, and a higher risk of hospitalization, but we didn't see other significant differences despite that larger group. Okay. Broken down into a subgroup that was presented at subsequent ID week, we did see that there was a higher risk of hospitalization, as I mentioned, for non-Hispanic Black patients, newly initiating or restarting ART at time of diagnosis, a CD4 count less than 200, or having syphilis at the time of diagnosis as well. So STI, co-infection, viral load, and CD4 count were predictors of more severe outcomes. So I want to talk a bit about the long tail of this initial outbreak. After we saw this outbreak, essentially, the majority of cases in the US occurred in summer 2022, so about 30,000 total. We saw very minimal spread after that throughout 2023 with a slight uptick in 2024. And that started raising concern that maybe something else was starting to happen with the Mpox itself. Maybe something with the virus, maybe something with how it was transmitting raised concern, and I'll go into why. So we were seeing about an average of 3,200 cases in August 2022 at the peak, down to just about 60 for the majority of this time period. And it remained within the same cohort that we saw in the initial outbreaks. So still cisgender men, majority gay or bisexual, and about half HIV, of them living with HIV, consistent with prior outbreaks. And just to get a sense of the curve, so essentially flattening, but then seeing an uptick in 2024 that started raising concern. Okay, so just to get a sense, in New York City, fast forwarding to 2024, because we started seeing daily case counts increasing gradually, a health alert went out warning us that clade 1 might be an issue for us to be looking at. And I'll go into what the differences are between clades 2 and clade 1. A reason behind this alert essentially was the knowledge that we didn't have great coverage with the vaccine in several groups that we were trying to reach. We were aware of the inequities that existed and essentially wanted to notify providers that we could be seeing something new on the way with Mpox. So, as I mentioned, low vaccine coverage. Nationally, we had about 23% vaccinated with 2 doses by the start of 2023. This data is from January 2023. 73% then were incomplete or not vaccinated. And we saw disproportionality with regards to groups who received the vaccine. Okay. So persistence over time, the reason that we became concerned and what it could reflect, a number of issues going into that. So delayed diagnosis, if folks just aren't aware that they have Mpox. Incomplete vaccination, as I mentioned, creates an opportunity for people to become infected with Mpox. Waning immunity over time, and I'll talk about what this means and why we're concerned about it, but also cryptic transmission. So cryptic transmission meaning folks who either have Mpox with really mild symptoms or no symptoms and don't realize that they have it, but have enough active virus that they can pass it on to someone else. So looking back at summer 2024, a study in Los Angeles did prospective interrectal swabs of folks, whether or not they had symptoms. Based on that, you can see the shaded line in the middle graph is looking at prevalence in anorectal specimens compared to the expected prevalence below in the dark line based on actual diagnosis. So they estimated that it could be a difference of 33-fold between actual reported cases and infections. Whether or not those estimates hold up, it does indicate that there is a significant amount of asymptomatic transmission that could be leading to Mpox persistence over time. And for us, it just indicates that if we're only relying on symptomatic testing, it might not be enough to capture a lot of cases that could then be passing on Mpox ongoingly. Okay. So with that, I want to talk about what has changed since 2024 and the reasons it's still relevant for us to be talking about now. So we have seen continued low-level transmission of clade 2B Mpox. We've seen continued circulation of higher virulence clade 1 Mpox strains. I haven't really talked about what clade 1 means yet, but I'm going to go into a comparison of that and what it means for us going forward. Clade 1b in particular has been spreading beyond endemic regions since 2023. Incomplete vaccinations and waning immunity raise concerns for what that means for both clade 1b and clade 2b. We have a lack of effective treatments, unfortunately. I'll get to that. And we're seeing persistent global transmission despite declining public attention, which always sets up the possibility of persistent spread. All right, so within the past month, you can see where cases are focused. We're still seeing them internationally, low-level transmission overall in the rest of us. Okay, so I'm going to go into a little bit of detail of what the different clades look like for us. So we've been talking mostly about clade 2b at this point. So clade 2b Mpox is spread between people, H2H in this table. After it was identified in an outbreak in Nigeria in 2017, the global outbreak that we're familiar with started in 2022. A public health emergency of international concern was declared by the WHO because of that. It spread in sexual networks among adult men who have sex with men. And this was a new transmission mode and enabled it to spread internationally, as we saw within sexual networks. Overall, fatality was very low, less than 0.1%, but in patients with or people living with HIV or severely immunocompromised conditions, you could see very severe complications, prolonged recovery, and a greater risk for fatality, so up to 15%. Notably, anogenital and localized mucosal lesions are seen in clade 2b. And those are what key us in to potentially that this is a sexually transmitted infection that someone has presented with. That said, localized mucosal lesions could be less symptomatic, not detected, as we saw in the other study. So it's good to be concerned anytime even subtle symptoms are mentioned there, or if testing worth considering. By comparison, clade 2a, zoonotic transmission, primarily seen in West Africa, with lesions at the contact site, very low fatality rate, and low frequency overall with low mortality outbreaks. We're not going to talk much about clade 2a. Clade 1, by comparison, clade 1a, older, traditionally zoonotic spread affecting children much more than adults, with a fairly high fatality rate in children. We see high fevers, many facial lesions, and primarily limited to the DRC. Has had increasing significance and incidence since 2017, but we're not really seeing this so much internationally. Clade 1b, by comparison, is what we are most concerned about becoming a greater epidemic internationally. So this spreads between contacts, so human to human spread. We see a mixed population, again a male predominance with anogenital and mucosal lesions seen, a much higher prevalence overall than clade 2b and severity in areas where it is causing outbreaks. This was an international concern declared in 2024 by the WHO after outbreaks were seen in 2023 and 2024, spreading among sexual networks for the first time with high virulence. And as we'll see, with outbreaks being established in new countries globally since then. Okay, as I mentioned, clade 1a, primarily zoonotic transmission and staying within endemic regions. Cases that we see outside of endemic regions are linked to travel without community transmission established outside of endemic regions. Clade 1b, by comparison, as I mentioned, higher virulence and has evolved to human transmission with sexual transmission as well. It was identified in a 2023 to 2024 outbreak as evolved for sexual transmission, and now it's spreading globally from that. As you can see, we've seen a number of cases linked to travel, but even more concerning, you can see that there's community transmission occurring in a number of countries across continents, including potentially the US, which we'll get into. Okay, so clade 1B Mpox, first identified in South Kivu, DRC. The concerning part, though, is that it started transmitting among household contacts, including among networks of sex workers, suggesting sexual transmission. So since 2024, we've seen almost 40,000 cases in DRC. By comparison, just to have a sense of magnitude, we've seen 104 in Spain, 19 in the US. About half of those in the US, though, have been in recent weeks, like the last 2 months, more or less. A recent outbreak in Pakistan, for example, demonstrating community transmission among neonates, infants, and adults. And higher mortality is seen in neonates, as well as the immunocompromised. And community transmission has also been seen in Singapore, Spain, the UK, Switzerland, Denmark, Colombia, and I would say probably the US as well. We'll get to that. Yeah, okay. So looking specifically at Southern California and why we're concerned about it here. So this is from May 2026, looking back at data from 2025, at where we were seeing cases imported. The concern for imported cases is that, of course, with increased frequency over time, that this can establish community transmission, especially if it's clade 1B cases, which have already shown that they can pass between household contacts pretty well as through sexual networks. So the more cases that we see imported, the more chance, of course, that this proceeds to onward transmission, which we have seen in Southern California. Okay. So clade 1B, we did see local transmission in October 2025 in hospitalized patients, hospitalized for Mpox-associated conditions like secondary infections, airway compromise because of mucosal lesions. This report was looking at 3 cases and then broadening that to 5 cases hospitalized across California. They saw that 4 out of 5 cases they identified were hospitalized. Compared to a much lower rate with the clade 2B outbreak. Of course, the sample size is quite small, so it probably doesn't capture that accurately. But the concern is that if this were to spread more, we might see more hospitalization with it. These were unrelated cisgender men who have sex with men within the same sort of age range we saw previously, 25 to 40 years old. And on further analysis, they trace this to 1 travel-associated infection, but they recovered prior to returning to California. So there wasn't really a great epidemiologic link with the cases either. Another reason that there was concern essentially for cryptic transmission in this case as well, potentially, because there was not a clean link between all of these 5 cases, essentially. Contact tracing was performed and 1 received vaccination as post-exposure prophylaxis. Okay. So this is not limited to Southern California. Of course, as we saw on that map, we've seen it in a number of countries internationally. 1B specifically, so nosocomial transmission in Ireland, Netherlands, and Berlin, even more recently, again, among men who have sex with men with high genetic relatedness in those viruses. And just to contextualize, we are still seeing clade 2 spreading. So in the past year in the US specifically, so total cases still close to 40,000. In the past year, about 2,700. Now, there are no deaths reported in the past year, which is good. Okay, so I'm going to go through some updates on vaccination and where we stand with that and what questions remain to be answered. Okay, so vaccination is with a number of different vaccines, but the one that we use in the US, the Jynneos vaccine, it's been added to the routine vaccination schedule for anyone with risk factors for Mpox infection. And those were defined pretty early on. So anyone with essentially more than 1 sexual partner, any commercial sex venues or large public events where they have close contact with individuals who might be at risk, and traditionally defined as gay, bisexual, sex men. And as I mentioned, we should be treating this as a syndemic and offering vaccination and services along with other sexual health services to enhance our reach. The doses of Jynneos are given 28 days apart. And for now, there is no recommendation for a booster or if you've been vaccinated or infected previously, that is also thought to give you durable immunity and is not necessarily recommended if you've recovered from infection. Okay, so just to compare the 3 vaccines that are available, 2 of them you've probably encountered. So the ACAM 2000 is the older vaccine based on the cowpox virus vaccinia. It's a replication competent live attenuated virus. By scarification, it's just 1 dose. Estimated efficacy at 85 to 87% based on earlier first generation vaccines. Only for immunocompetent folks, unfortunately. But our newer modified vaccinia and Cora, it's a non-replicating 3rd generation vaccine based on the modified Cowpox virus. This is the 2-dose vaccine that we were administering as Jynneos. And this is given either intradermally or subcutaneously, estimated efficacy at 75 or 85%. That higher range being for folks who receive 2 shots rather than just 1. A different vaccine is used in Japan, a single dose. However, that one is contraindicated. The immunocompromised was suppressed because it is a live attenuated virus. There are a number of candidates in the pipeline, unfortunately beholden to funding and interest, but platforms being looked at include mRNA, multiple different live attenuated options, as well as protein subunit vaccines. And this is just having a sense of the infection seen after 2 doses of the Jynneos vaccine into 2023 and 2024, just demonstrating that it does happen, even if folks are fully vaccinated. The proportion of cases over time with full vaccination varied, but you can see in 2023, up to almost 40% of cases were folks who had full vaccination. So what does that mean for us? We're seeing clusters in vaccinated individuals. In Chicago, an outbreak between March and June 2023, 40 cases per lab confirmed. 55% of those had received 2 doses or 1 dose of the older vaccine. And most of them had been vaccinated in that original outbreak. So it wasn't even a full year after their full series had been received. So raising concerns about whether those vaccines had taken, efficacy concerns, but also whether a booster might be necessary. So the question of whether boosters are next or not, it remains an open question. I'm not going to be able to resolve that today, unfortunately. But we do see a declining antibody response after vaccination. We see that in non-human primate studies, those levels do correlate with protection. In a Boston study, you saw that neutralizing antibodies declined at 6 and 12 months. And after 2 doses at the 1 year, essentially their response level was similar to folks who had received just 1 dose. And that raises the question of whether a booster at that level might get you back to the same level of protection that you had previously. Another sample looking at similar question saw that new vaccination produced less response than folks who had previously had Mpox or who had previously received vaccination for smallpox. And then you do see that lower response is seen for vaccination compared to natural infection with Mpox. So a Belgian cohort that was looking at patients over time vaccinated about 8 months later saw a very limited response at all. Lower concentrations of antibody responses were seen in folks who received intradermal vaccines. And that's important because intradermal vaccination was performed as a way to extend the supply of vaccines during the outbreak when it was unclear whether we would have enough to cover everyone who would be at risk before we had a sense of how big the outbreak would become. So this raises the question of whether that's going to create a different response over time for folks who are expecting to be fully vaccinated by the intradermal route. So natural infection, by contrast, induced durable immunity at 2 years, at least in the antibody responses they were looking at. Now, it's an open question of how that correlates with actual protection over time. But we will see as the years go on, essentially. Patients with prior smallpox had boosted immunity for up to 2 years after either vaccination or infection. So it did produce a sort of booster effect if they had had prior smallpox vaccination. But this does raise questions, of course. As I mentioned, we went to the intradermal route to extend our supply of vaccines. Even in large cities like New York, where we had a disproportionate supply of the global vaccine supply overall, that sort of rationing was taking place. So in these vaccines that are difficult to get to resource limited areas, does it make sense really to boost folks when we don't have equal distribution to begin with? So just something to think about as we have those conversations. Okay, so I'm going to look at treatment and where we are with that. Unfortunately, it's not looking great. Okay, so back in our initial outbreak, we had a drug called tecovirimat, essentially obtained through an emergency authorization from the CDC and FDA that had helped set that up, intended to be for folks who were expected to have severe manifestations. So severe immunocompromise, severe skin conditions, HIV with a CD4 less than 200, and lesions that were expected to lead to severe outcomes, essentially. We didn't have clear efficacy data to support this broader use. And we already knew that there was a low barrier to developing resistance. So the STOMP trial was set up alongside this emergency access authorization in order to answer some of those questions. So the STOMP trial, or study of tecovirimat or Mpox, it was intended to enroll the majority of patients, whether or not they were expected to have severe outcomes or were at very high risk. So any adults with Mpox were eligible, including mild disease. However, if they had severe immunocompromise, like an immunodeficiency, severe skin conditions, or severe disease, then they would be enrolled in the open label arm, rather than being double-blinded and randomized placebo. And the map on the right, just to get a sense of where this was taking place, it was relying on its clinical trial groups network across 80 US and international sites was the goal. And just to get a sense of how complex this could become for us at the time, the majority of folks essentially obtained tecovirimat through the emergency access IND ultimately, and not through the clinical trial itself. There was a lot of overlap for which one you could qualify for, but if you had delayed onset to presentation, had received TPOC or tecovirimat previously, then you were really only eligible for emergency access. It had to be mild and within 14 days to be included in the clinical trial. So just to get a sense of the actual numbers, so this is looking at 2023. So this is unfortunately after the peak of the outbreak, but by the time the clinical trial was set up, ready to enroll actively and going forward, you can see in the little lightest box, patients enrolled in STOMP, trailing behind, unfortunately, patients who were enrolled under the emergency access program. And both of those are trailing behind the number of cases that we were seeing. So enrollment was very slow. Eventually, though, we were getting more folks enrolled in STOMP than the emergency access protocol. So its intended purpose was met by the time by mid-2024 in terms of enrollment. Unfortunately, we didn't see positive outcomes in that trial. Out of 344 adults included, essentially entirely male, 49 sites across 7 countries. And by day 29, we did not see improvement in primary outcomes, which was time to clinical resolution. So tecovirimat did not improve Mpox the study. Limitations including late presentation. So 75% of folks presented more than 5 days after onset. So that remains a question of whether antivirals would be more effective earlier in the course. However, because of a number of reasons, including cryptic transmission, just time to actually getting to care and getting tested and getting a result, this will continue to be a challenge going forward. Immunocompetent adults were the only ones included in this arm. As I mentioned, the open label arm was used for anybody who was expected to have severe outcomes or who did end up developing severe symptoms. So it was underpowered to look at patients with immunocompromised or severe immunodeficiencies. And we had very challenging enrollment, as we saw with the EA-IMT being available. Okay, and then in the open label arm, similar outcomes were seen. Essentially, you did not really see improvement with tecovirimat because of the way that the study was set up, though we can't state about significance. So looking at clade 1 Mpox, just as a refresher, clade 1, 1A, zoonotic transmission, 1B, human to human transmission with more virulence and increased spread internationally. So looking at the PALM 007 trial, this was using tecovirimat specifically for clade 1 Mpox, and nearly 600 children and adults were included in the Democratic Republic of Congo, and this was in a 1-to-1 ratio. So you did not see improvement in time to lesion resolution, unfortunately, for clade 1 Mpox either. Looking at subgroup analysis, they were able to identify that some trends in baseline characteristics would affect your time to resolution, but tecovirimat itself did not affect time to lesion resolution. Virologic endpoints were similar among all subgroups, essentially, and not correlated with outcomes. So another reason that our testing for surrogate markers of either infection or immunity, whether this is looking at virologic load or neutralizing antibodies over time, are not really capturing the full picture with what folks are going through with Mpox. And evaluation capacity was limited there. With regards to self-reported endpoints, the population was pretty variable among sites that they saw. So remaining questions, as we've gone into a bit, but what correlates of protection can we look at from vaccination? What is the real durability of immunity over time after vaccination? Is looking at these broadly neutralizing antibodies really telling us anything? I would suspect it's telling us something because we're still seeing those breakthrough infections, but the complete story remains to be answered. We know that there are many, many mutations that affect the efficacy of tecovirimat. So there are a number of envelope protein mutations that essentially disable its utility for Mpox. So what does that mean for our trials? Has this been all due to resistance? Has this just been due to when they are receiving treatment? Has this been due to regional variability in the clades that patients are experiencing? Or is this anything specific to the route of transmission and the site that folks are affected by? And are there alternative therapies that we should be reconsidering, and what are those? So looking at some of those alternative therapies, so tecovirimat initially was approved for smallpox and complications of vaccinia vaccination, made available for Mpox through that emergency access, and a number of trials have failed to show efficacy for that. Cidofovir, an IV antiviral used for CMV retinitis. We've seen case reports and preclinical trials for Mpox, but it's not approved for use. Cidofovir, a PO form approved for smallpox, is being studied for Mpox. Hasn't shown efficacy yet, but it is still in some trials and can be obtained through emergency access in the US. Trifluridine is used for herpes keratitis. and has been used in some case reports and preclinical studies for Mpox, ocular lesions, and IVIG, used for complications of vaccinia smallpox vaccinations, has been used in some cases of very prolonged infections of Mpox in hospitalized patients. But again, none of these have enough data to really widely recommend them, and on a case-by-case basis can be considered. So our chief at UCSD, Dr. Wilkin, wrote a op-ed essentially calling for more therapies to be investigated for Mpox. And just to summarize some of those that are under consideration, ongoing trials through the NPX response project based on an observational mosaic cohort, including the Unity trial, the epoxy trial, and the MOSA trial. MOSA is notable because it includes multiple antivirals and is set up as a platform to essentially demonstrate how the studies can be done and be used for successive treatment trials. Right now, the first candidate they're looking at is here. A number of investigational drugs have been proposed and are being studied, including tecovirimat prodrugs, some targets of resistant tecovirimat strains, as well as bispecific antibodies, and repurposing older antimicrobials or natural compounds as well. Of course, funding and interest are a lot lower than they were at the time of the outbreak, so this will depend on that going forward. Okay, so I want to talk a bit at the end just about what we can take away from this for emerging infections in the future. So our Mpox response relied on a number of entry points to care that we've talked about: HIV clinics, STI programs, PrEP access programs, public health clinics across New York, and harm reduction sites. And our coordinated response relied on hospital networks, the health department, and community groups working together in coordination with the FDA and CDC. NYU's response was similar to ours, just to reflect how this went in the outbreak. The EAIND available early, and then TPOXX providers being trained over the course of time. So essentially, the strengths of our efforts were that we leaned on these HIV care networks and the public health and ID systems that we had already set up citywide. We had scalable outpatient treatment systems in place. Rapid diagnostics were available as early as we could get them. We made vaccines available with a low barrier to receiving them. We had treatment available to the best of our abilities, of course, with the barriers I mentioned. Culturally competent and stigma-aware messaging was very important to get folks into care. And then we monitored outcomes over time to establish treatment efficacy and adjust our response as it was ongoing. So just to quickly mention status neutral care. We've kind of touched on what this is throughout the talk, but this is part of why our response was what it was, that we were capturing folks who were already involved in prevention, whether it was HIV or STIs, or in many cases, just primary care. And we were also including folks who are already in treatment. So regardless of HIV status, folks were wrapped into the systems that we had set up already, and we just scaled them up to be as accessible as possible. And looking at the national response, just national numbers over time, essentially over 50,000 genomes doses distributed over that summer. And I'm going to skip through this, but essentially looking at the first 100 days of the international response, by the end of those 100 days, we had those 3 vaccines that I mentioned, but no approved therapeutics, just investigational drugs. And we did have some testing available though, with WHO authorization. A blind spot going into future epidemics though is surveillance. It was extremely difficult and slow to get PCR tests up and running, even in the US. But internationally, we had extremely limited availability in remote settings. No point of care tests available, no rapid diagnostics available, and only the DRC had significant regional capacity in 2024 during the second global health emergency that was declared. So going forward, this is a focus point in whatever we're looking at. And I mentioned that because there are a number of concerns that could be coming up next. So novel STIs, including Mpox, but also TM7, fungal STI, dermatophillosis, a zoonotic illness that is now spreading among sexual networks, resistant STIs like Shigella and Mycoplasma genitalium, or even zoonotic infections that have evolved to sexual transmissions like dermatophillosis, Mpox, and even Ebola. So in conclusion, our HIV and STI infrastructure became the response infrastructure. We leveraged community partners and integrated into public health systems for a status neutral approach, and we're able to scale that up effectively. Biomedical tools were unfortunately insufficient. We had incomplete vaccine update, waning immunity and breakthrough infections are continuing to be seen, and tecovirimat ultimately failed. Mpox became a persistent global threat, as we've seen with 2B as well as Clade 1 expanding its range. We see a very fragmented global health infrastructure today, especially, which is going to make responding to future threats like this even more difficult, unfortunately, because we do require an integrated and scalable response with diagnostics, coordinated public health surveillance, and adaptable care. So, something to think about going forward. All right, and then just a couple more references to look at later, and a thank you to everyone who helps get through this outbreak and the ones that we'll face in the future. And of course, thank you to all my mentors at Sinai, Dr. Chasen, Dr. Patel, Dr. Marsha Wong at the Department of Health, Dr. Chris Vo, our alumni from UCSD, and my mentors over the year, Dr. Avery, Dr. Abert, and Dr. Thank you so much for all your guidance. Okay.
Thanks, Rustin, for an outstanding talk. I do have one question from Nettie Aldis. Any role or investigation of topical treatments for localized lesions, i.e. like genital lesions?
Sure. So there have been some case reports, essentially of topical cidofovir has been used in some cases, and then trifluridine in ocular cases, but they're still limited to just essentially consideration in severe cases or a refractory disease that isn't improving, because there's nothing that has really good efficacy data yet, unfortunately. No. But it is worth considering in severe cases still.
Okay. So I'm going to go ahead and open up the chat line, or I guess if people have questions, maybe I'll start here in person. Does anyone have any questions here? For those online, if you can use your raise hand icon, that'd be great. Any questions here?
I guess I'll ask one. How many, if you had to estimate, like breakthrough cases might there have been in people who have been vaccinated, and how common and do have those tended to be intradermal versus sub-Q?
So in terms of number of cases overall, the number of cases is still pretty low, but as we saw in some cases, up to 40% of those were folks who were vaccinated. So it's really variable, but I would say it can be a significant portion. I don't think we're seeing enough cases for it to have an estimate overall yet, but at least in terms of, let's see, so in terms of
If we know intradermal and sub-Q,
in terms of intradermal, we have seen that there is less of a response over time. I'm not sure that we have data on whether guys folks got it intradermal. I have to double check.
No, thank you.
Good question. So we're working on developing a protocol here, mostly for individuals who might present with severe Mpox or who are severely immunocompromised and at risk of progression to severe Mpox. And we're looking at a combination of tecovirimat and brimcidofovir. But I'm just wondering, your experience at Mount Sinai or at USC, have you developed protocols, or whether what has kind of been the approach at your other institutions?
At least in the initial outbreak, what our approach in more severe cases was we would continue tecovirimat, whether it was IV or PO, we would be sending resistance testing out to see if that was an effective approach or not. But then we would also be incorporating second line therapies at the time. So like IVIG was used a number of times. We would use topical therapies like the trichloroidine and cidofovir. Beyond that, we were not using brincidofovir at the time. We did use it a bit later, like in fall and into spring, but we didn't have a protocol specifically for examining like a combined. I think going forward, what would make most sense, of course, because they are studying it in MOSA, would be brincidofovir, because that's been the most promising, at least out of the investigations they've done so far. And it is much easier to tolerate than cidofovir, so as you know, so that's
Good. Anyone online, if you can unmute and ask your question.
Question.
We have a question here, Aaron.
Thank you. Is there a clinically available antibody test? I'm just thinking about, you were talking about the correlation between immunity either from vaccine or from acquisition in relation to prevention and not getting a subsequent infection. And I'm thinking about hepatitis B and how we, some people have waning immunity, so we check their antibody levels to find out, do they need a booster vaccine? Is that something that's being developed in this space?
so we don't really have a good correlate for protection yet, unfortunately. So there's nothing that we could really look at.
So even if they have antibodies, it's not.
No, because they haven't quite linked those to what it means clinically yet, so it wouldn't make sense. At least in our setting, we would still be kind of scratching our heads though about what to tell the patient based on that. Unfortunately, it might get to that point, but not quite yet.
Any other
I have a
questions?
question.
Sure.
First thing, that was a very comprehensive review, and I remember the slide where he says there's like a looming epidemic here in Southern California. So I'm just wondering what your thoughts might be after looking so deeply at all of this. Like any recommendations for what those of us
I
working
would
in
say,
Southern
yeah,
California can
so
do.
that's a great question. Thank you for that. I would say what's most important is to have a really low barrier for testing and a really low, it's just like a high, mixing metaphors, but yeah, just, anything that you're concerned about in a mucosal area, even if it doesn't fit a classic Mpox pattern, even if they don't have a rash, they don't have a viral prodrome, they don't have anything, right? It could just be very subtle. If you're going to be testing for any other reason, think about including Mpox with that swab.
Yeah.
I would say. And then if you start noticing that, oh, wow, that was unexpected, I have a positive Mpox, then we'll start going from there. Yeah.
Right. Any other questions, comments? No. All right.
Right on time.
Well, we want to thank Rustin for an excellent talk. And we will see you next week at High Rounds. Have a good weekend.
All right.
Thank you.
Thank you.
Thank you.